This is Heart Rhythm TV. I'm Roderick Tung. We have yet another consensus statement, the 2023 Expert Consensus issued by the Heart Rhythm Society on the management of arrhythmias in pregnancy. And with me today on Heart Rhythm TV, we have Jose Joglar from UT Southwestern in Dallas. Jose, welcome to Heart Rhythm TV.
Thank you for having me, Rod. It's a pleasure to be here.
I was just on consultative cardiology last week, and we got called about bigeminy in a pregnant woman. Nobody wants that consultative phone call. This document is so necessary, and I understand you've been working on this for a while.
That's right. We started this before the pandemic, but then the pandemic delayed us for obvious reasons, and different priorities came up. But exactly what you're saying, when a pregnant woman is having arrhythmias, everybody runs away from her, like if it was a COVID infection, a COVID ward, and we like to change that. That's very important to emphasize. We like to change that. Pregnancy is not a disease, Pregnancy is a physiologic state. And the fact is that when you have arrhythmias in pregnant women, then you have two lives at risk. And especially when those arrhythmias have important hemodynamic consequences. So that's a message we want to bring loud and clear to our medical community.
And Jose, how many documents has the Heart Rhythm Society issued on management of arrhythmias in pregnancy?
This is the first one. Let me tell you a little bit about the fact that I have been engaged also in the ACC/AHA guidelines, and usually what you have is a little section on pregnancy. For example, if you have a guideline on SVT or on ventricular arrhythmias, then you will have a small section that covers some aspects of the management of SVT or whatever arrhythmia the guideline is hitting, the topic is hitting on pregnancy. So what we wanted to do is had a comprehensive guide, a comprehensive statement where the entire management of arrhythmias in pregnancy, not only for pregnant woman, but also for the fetus, is included within one document. So physicians can have access to one guide for all their needs on how to best manage these patients.
And what's beautiful about that is obviously we've relied on these sub-documents from ACC and AHA, but now hopefully this can translate over, that this HRS-led document can then apply to all general cardiologists and consultative cardiologists.
But also, not only that, but also we can be more comprehensive. We can be more expansive. We can provide further details. Usually, guidelines provide just partial aspects. The most important, just highlights on the management. But now we can be more comprehensive.
So take me through my consult and give me a consult for the consultant. What drugs are safe in pregnancy? Antiarrhythmics.
So we need to, one message we bring in loud and clear is that we treat pregnant women, for most part, with few exceptions, the same way we treat any other patient. And the same drugs that you use in regular patients, like beta blockers, 1C agents, are generally safe in pregnancy. Certainly, the problem with pregnancy is we don't have large randomized trials. As you know, pregnancy tends to be an exclusion criteria for most studies. So we actually rely for our evidence on experience-based. So we give a stronger class of recommendation to drugs that have the longest record of safety, like metoprolol, propanolol, flecainide, sotalol, things of that nature. But in general, very few drugs will be absolutely contraindicated in pregnancy, very few drugs.
Say amiodarone?
Even amiodarone you can use when the benefit outweighs the risk. Even amiodarone is not an exclusion. Amiodarone carries some significant toxicity to the fetus. But like I said, the priority is to stabilize the patient, to get rid of that arrhythmia, especially when it is hemodynamically important. So even amiodarone is an option under the right circumstances.
And I think the other breakthrough that's worth discussing is just the emergence of fluoroless procedures or minimal fluoro procedures, right? Is that previously it was always felt that the radiation exposure was an absolute contraindication. And now here we are 10 years later, And so many procedures are fluoroless. When I trained, it was nonstop fluoro watching catheters move around.
Right. But even if you have to use fluoro, like I said, we try to emphasize that the priority is to stabilize the patient, to get rid of that hemodynamically important arrhythmia that can pose a significant risk to mother and the fetus. So I think that the risk from fluoroscopy, even during the old days, is exaggerated. The fact is very few cardiac procedures exceed the threshold of risk for long-term malignancies. And like you said, even more today when we have the technology to do procedures with minimal or zero radiation. But even if you have to use a little bit of fluoro, the fetus gets a little bit of scatter, doesn't get direct radiation directly from the beam. So in general, the priority is to go ahead and take care of the patient because, like you said, the radiation is really it's a non-issue in my view.
Well, I love it. And I think that our readership is going to really value this document because it's going to help you in a pinch. And the fact that it's so comprehensive is going to be a wonderful read. So, Jose, congratulations on a very thorough review of this very difficult area where we're getting people to run towards pregnant women now rather than running away.
I'm hoping so. We're trying to get rid of some ideas. The old classification of drugs, many drugs, because they were never tested, got category C. That meant we don't know, but we're trying to make people think differently. I have to say also, I like to get I have to say thank you to the writing committee members. There are 20 world-class experts on the field from across the planet on different aspects of arrhythmias pregnancy. We had obstetricians and electrophysiologists and cardiologists, etc. So it's been a very good group. So I'm very proud of this document. Like you said, we're trying to change the way we view this problem. Like you said, we like hoping that physicians are not afraid of taking care of pregnant women when needed.
Yeah, well, we got this now with this document. Congratulations, and thank you so much for joining us on Heart Rhythm TV. It's going to be a great read for everyone.
Thank you so much. Glad to be here.
Thank you, Jose.
Thank you.